one of the big questions that we always have when a patient is failing therapy, whether it's with morphologic relapse or with MRD relapse, which is becoming increasingly a hot topic nowadays, although could be controversial. But one of the big questions that come through, especially in patients who are eligible for stem cell transplant, is what do we do with them? What can we give them? And you often have the option between intensive and lower intensity therapies. Before the novel therapies came through, majority of patients would have gotten high intensity therapies, and they do come with a lot of toxicity. And with venetoclax coming into the horizon, one of the opportunities for us is to look at, can we use something that has been shown to be effective in the front line, now using it in a relapse or the salvage setting and seeing whether we get effectiveness as a bridge to stem cell transplant. So we looked at 14 patients who are destined for transplant. They have donors, we're almost ready to go, but often there's a little bit of time, you have some logistics. And so we had 6 patients with frank morphologic disease that we gave venetoclax combined with lower intensity therapies, either azacitidine or low-dose cytarabine. And what we did see is that 4 of those 6 patients actually had blast clearance, 1 with count recovery, 3 with just morphologic leukemia-free state. But what we could do is to get them to transplant. The other 8 patients that we looked at are patients with MRD relapses, and we are now increasingly understand that when someone has an MRD relapse, they are likely going to do quite badly in the very near future, and salvaging them at a earlier time point where they are fit and well may be the optimal thing to do. We don't know. We're still waiting for a lot of trial data to come through on that space, but we managed to really eradicate the MRD in some cases. But what I guess one of the things is, whilst waiting for the transplant to happen, we could deliver lower intensity and safe therapies. Only 50% of patients had febrile neutropenia. We had no mortality on our therapy, and perhaps this changes the way we look at salvage treatment in AML patients in the future. And so we thought this retrospective case series could add a bit more to discussion about what is the right salvage to use for patients who are relapsing treatment when we are heading to a transplant.